It's Patrik Hutzel from IntensiveCareAtHome.com, where we provide tailor-made solutions for long-term ventilated adults and children with tracheostomies, where we also provide tailor-made solutions for hospitals and intensive care units, whilst providing quality services for long-term ventilated adults and children with tracheostomies, and also otherwise medically complex adults and children at home, including home BIPAP, home CPAP, home tracheostomy care, when adults and children are not ventilated, also home TPN. We also provide IV potassium, IV magnesium infusions at home, as well as IV antibiotic infusions at home. We also provide port management, central line management, PICC line management, Hickman's line management, as well as palliative care services at home. And that also includes ventilator weaning at home. Now, today I want to answer a question that we get quite frequently from our clients, but also from hospitals as well. And they ask, how important is discharge planning for intensive care at home clients or intensive care at home patients? Well, discharge planning when going home from hospital is everything. You know, that really sets the scene, and it really is a make or break point. And, you know, we have done so many successful transitions from ICU to home to improve the quality of life for our clients, and in some instances improve the quality of end of life for our clients. You know, it's really a critical point to make it a successful transition for intensive care at home clients, which includes the patient and the family, of course, but it also includes the hospitals, because, you know, the goal for the hospital is to discharge patients into a safe environment, making sure they're not coming back. You know, that's the whole purpose of intensive care at home. So let's look at this in more detail. So first of all, you know, you have to identify the right client or the right patient that they can benefit from intensive care at home, that they can improve their quality of life at home, or in some instances, quality of end of life at home. And predominantly it's for patients with ventilation and tracheostomy, adults and children, right? They have been identified as having the inability to wean off the ventilator and the tracheostomy for now. That's not to say they might not be able to do that later, but it would take long periods of times, and hospitals and ICUs in particular are often not the right place, because, you know, they are very depressive environments with no quality of life. And, you know, one of the obstacles for patients to wean off a ventilator is simply they're not in a patient and family friendly environment. You know, anyone that set a foot into an ICU knows it's, you know, it's just there to help treat critical illness and save lives, and that's fantastic. But at some point, when someone is stuck in there long term, it is no longer the right environment for them. It's also no longer the right environment for the families, because they more or less live in ICU, quote unquote, live in ICU, and that's not a good thing either. You know, moreover, ICU beds are in short supply, right? Critical care beds are in short supply. Critical care beds are the most sought after beds in a hospital, right? So therefore, freeing up an ICU bed and moving patients home if they can't go to a hospital ward or hospital floor makes a lot of sense and is a win-win situation. So we've identified the right patient. In some instances, it can also be a patient that is having a tracheostomy but is not ventilated, but still needs frequent suctioning, needs frequent treatment. You know, the reality is that when you look at the evidence, you know, a patient can't go home without having, or when having tracheostomy or tracheostomy ventilation, without having 24-hour nursing care with ICU nurses who have a minimum of 2 years ICU or critical care nursing experience. Only that is evidence-based and safe. And I encourage you to read up our mechanical home ventilation guidelines, who are evidence-based, right? And you can have a read there what is actually safe. Now, moving on from identifying the right patient and obviously establishing that in ICU, there is no quality of life, no quality of end of life. Patients are depressed, often families are depressed, right? And that is not a good situation to be in. Next, we got to look at the home of a patient, right? We got to look whether the home is suitable for intensive care home. Most homes are. It's probably less of an obstacle than you think it is. You know, some homes might need some modifications. You know, you might need a hospital bed, you might need a hoist, a ceiling hoist in particular, like a lifting machine, right? But it's all doable, and most homes are absolutely suitable for it. We have worked in so many environments, and we can certainly help you find out whether your home is suitable or not. Next, we got to look at the equipment, right? What ventilators are needed, what size tracheostomies are needed, suction machines are needed, monitors are needed. Sometimes a cough assist machine is needed, right? Tracheostomy dilators are needed, spare tracheostomies are needed, resuscitation bags are needed, like air vivas, right? And you always need to have two of them. You can't just run on one ventilator, one suction machine. What if it breaks down, right? We also have to probably look at, like I mentioned earlier, hospital beds, wheelchairs, emergency packs. Sometimes oxygen is needed at home, but we have a checklist of what is needed. We have done so many successful transitions from intensive care to a home that, we have a lot of experience making a successful transition for you as well. Next, funding needs to be sorted, but it's probably less of an obstacle than you think it is. Keep in mind, if you're watching this and you are in intensive care, or you have a loved one in intensive care long term, think about this. Someone is paying for the ICU bed, right? Some insurance is paying for the ICU bed, most likely, if you're watching this. In most Western countries, US, Australia, the UK, an ICU bed costs around $5,000 to $6,000 per bed day. Let that sink in. $5,000 to $6,000 per bed day for a 24-hour period. Intensive care at home is approximately 50% of that cost. It's a win-win situation, right? So there is not only a very compelling humanistic aspect in getting you and your loved one home, there's also a very compelling economic and financial aspect to getting you or your family member home, right? Once again, it's a win-win situation. Everyone is winning here. Plus, you're freeing up the ICU bed, right? It can't get more win-win than that. Next, medical governance as well as nursing governance, right? So you got to look at the medical governance. Sometimes we work with GPs or family doctors. Sometimes we work with respiratory physicians. Sometimes we work with intensivists. Sometimes here in Melbourne in particular, we work with the VRSS, the Victorian Respiratory Support Service, who gives medical governance. Sometimes we work with children's hospitals. We work with the Children's Hospital in Melbourne on many occasions, who provides the medical governance. And thank you to those organizations. And sometimes we provide it through our own doctors in our network. So it's not a one-size-fits-all, but it is definitely doable. And once again, that is also something that needs to be looked at. Next, if you're watching this and you are an NDIS participant, right, or you are a family member of an NDIS participant, what also makes or breaks often these situations is a good NDIS support coordinator, right? Obviously, we are currently operating all around Australia in all major capital cities, as well as in regional and rural areas. And many of our clients are NDIS participants, and a good NDIS support coordinator for clients with complex medical issues, or complex medical disabilities, which is what our clientele often is, need a very good support coordinator, NDIS support coordinator, and we can help you with that. We have a good network. We have our own NDIS support coordinator, and we would really like to help you as well with NDIS support coordination, because this is absolutely critical. But even if you're not an NDIS participant, if you are TAC, iCare in New South Wales, NIISQ in Queensland, or any other insurance scheme or private health insurance, or you're affiliated with the Department of Health, you need a good case manager, good advocate one way or another. And we have always been involved in successful advocacy for our clients. Otherwise, we wouldn't be doing what we are doing. Next, team. You need the right team. Okay, so one thing that we always say is we are not an agency. We are a unique specialist service provider in the intensive care at home space. And therefore, we have a tailor-made solution for our clients, right? And a tailor-made solution includes creating a team that works for you. Creating a team with the right individuals on the team with the right skills, right qualifications, but also more importantly, with the right mindset. Mindset is critical, right? You don't want to repeat your experience in the hospital in an ICU. You know, one of the reasons you got depressed days, you didn't get what you felt like you needed there, right? So at some point, going home is critical with the right team. And, you know, we've been in business for over 10 years. We know who's suitable for a home care environment and who isn't. So, you know, we are able to create the right team for you and select the staff with your input, of course. Next, the right care plan, right? With the right goals of care. Very important that, you know, a care plan is being documented before you or your loved one is going home. You know, again, this will work in combination with yourself. You know, it's about choice and control. It's about working with your family. It's about working with the hospital, but really mapping out what is it that you want and identify a care plan. Next is, you know, a lot of families are asking us, not a lot of families, it's actually not accurate. When we have nurses applying for our roles, or sometimes we have doctors as well, they ask us, okay, so most of your clients would have a DNR or an NFR, meaning they are choosing not to be resuscitated in case their heart stops. Well, you'd be surprised. Very few of them do. Most of them want to live irregardless of their perceived limitations, right? So most of them, when they're at home, live a very good quality of life, right? Which is the whole purpose of them going home in the first place, right? So, you know, discussions around NFR, DNR can take place, but you'd be surprised at the end of the day, it's patient and family choice and control. And very, very few patients choose a DNR or an NFR. And that says a lot about our service. And it says a lot about the individuals, you know, how they approach life, and that a disability or a medical issue or concern is not holding them back to want to live life, you know. And that is very important. It's a very important aspect of what we do. We enable our clients and their families to live life the way they want it, without any restrictions, without any judgment. You know, this is your life, and you do what you feel is right for you. Now, so I hope that sums up, you know, what is important for discharge planning when you go home with intensive care at home. And you know, just one more comment about the care plan in particular. You know, a care plan should really focus on maximizing your quality of life or quality of end of life at home, and not go back to hospitals. That's very important, and that's one of the major promises of our service, that you don't go back to hospital, that you stay home predictably, right? And it's something you should be thinking about carefully, how that can happen. Well, we know it can happen because we make it happen every day for our clients so that they don't go to hospital. Okay, so now, intensive care at home, we are currently operating all around Australia, in all major capital cities, as well as in regional and rural areas. We are an NDIS approved service provider all around Australia. We are a TAC approved service provider in Victoria, as well as WorkSafe. iCare, we are an iCare approved service provider in New South Wales, as well as an NIISQ approved service provider in Queensland. We're also a DVA approved service provider all around Australia. We have also received funding through public hospitals, departments of health, as well as private health insurance. So reach out to us if you need help. And if you're at home already and you're going back to hospital or to ICU all the time because you don't have the right level of support, please reach out to us. We can help you with funding. We can help you with staff. You know, we can help you achieve your goals. We are also providing level 2 and level 3 NDIS specialist support coordination if you need help with that. We are also providing NDIS specialist nursing assessments if you need that for yourself or for your NDIS participants if you are an NDIS support coordinator. And if you are an NDIS support coordinator watching this and you need nursing care for your participants, please let us know. Or if you need funding for nursing care, once again, we can help you with the nursing assessment and we can help you with the advocacy. We are also sending intensive care nurses and critical care nurses into people's home to avoid emergency department admission. So we're also providing an emergency department bypass service. Now, and if you are a critical care nurse and you're looking for a career change, we want to hear from you as well. If you have worked for a minimum of 2 years in critical care, ICU, or ED, or pediatric ICU, and if you ideally have completed a postgraduate critical care qualification, we currently have jobs in Sydney, Melbourne, Brisbane, Albury, Wodonga, as well as in Bendigo, Country Victoria, as well as in Warragul in Country Victoria. We want to hear from you. We are really looking for ICU nurses or CCRNs that want to complement our team. People who are team players and people who are looking for regular work. We are a service provider with a tailor-made solution for our clients, and we are not an agency that have people coming and going. We pride ourselves on providing that tailor-made solution to our clients. So if you're looking for agency work and you want to come and go and pick up shifts as you want, please don't apply. This is not for you. Only apply if you want to make a difference to our clients' lives and if you want regular work, and that includes with our clients on a regular basis. And if you are an intensive care specialist, we are currently expanding our medical team. We want to hear from you as well. And if you are an intensive care specialist and you have bed blocks in your ICU, which I know that you do, I encourage you to reach out to us as well. We can help you eliminate your bed blocks, but more importantly, we can improve the quality of life and sometimes quality of end of life for your patients and their families. And if you are a hospital executive watching this, we also want to hear from you because, again, we can help you eliminate bed blocks in ICU, pediatric ICU, and ED, and also on respiratory wards. Please reach out if you want to have a conversation. Our website, again, is intensivecareathome.com. Call us on one of the numbers on the top of our website or send us an email to info@intensivecareathome.com. Now, thank you for watching. If you like my videos, subscribe to my YouTube channel for regular updates for intensive care at home, but also for families in intensive care. Click the like button, click the notification bell, share the video with your friends and families, and comment below what you want to see next, what questions and insights you have from this video. Thank you so much for watching. This is Patrik Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.